Hi everyone, I'm Raj,
I'm Eddie.
and this is Blood Cancer Talks. We are a podcast dedicated exclusively to hematologic malignancies, where we bring in content experts who live and breathe a particular disease, and we focus on the latest advances in clinical management. Please take a moment to rate and review our podcast in whichever app you listen to your podcasts in. Today, we are excited to talk about updates in the treatment of newly diagnosed transplant-ineligible multiple myeloma. We have two important randomized controlled trials in this space, recently presented at ASCO and EHA and published simultaneously, namely IMROZ trial and BENEFIT trials. To discuss these, our guest today is Dr. Timothy Schmidt from the University of Wisconsin at Madison, who is an expert in all things myeloma. Tim, welcome. Before we start, can you tell us about your clinical and research focus and one or two mentors who inspired you to focus on myeloma?
Sure. So yes, thank you for having me today. Happy to be a part of the discussion. So my clinical focus is in multiple myeloma, plasma cell disorders. So that includes anything from symptomatic myeloma, newly diagnosed, relapsed, auto transplant, CAR T, as well as precursor conditions and AL amyloidosis. As a clinical researcher, I'm very focused on clinical trials and kind of new drug development and things like that, but also working across in multi-center collaborative groups to run innovative trials and then pool data together to look at outcomes. And then one of the areas that I've been more specifically involved with is risk stratification, which in myeloma is a long conversation in and of itself. How are we going to try to predict who's going to do well and who is not? And I've had I've been fortunate to work on some projects trying to help clarify the impact of a specific translocate or aneuploidy with gain or amplification of 1Q, which is pretty common in myeloma and heavily debated what that actually means. But that's one of the areas that I've had a little bit of interest, but certainly anything goes with plasma cell disorders, and newly diagnosed transplant-ineligible or eligible is a big focus of mine. You had wondered about mentors. As a fellow, I went into fellowship undetermined, undecided what I wanted to do. But at Emory—
Undifferentiated.
Undifferentiated, yes. Which you don't really want in heme malignancies. But as a new fellow, it works well. And I was fortunate to cross paths with some of the great myeloma doctors at Emory University, and Jonathan Kaufman in particular was a great mentor to me. And I also had a chance to work in the lab with Larry Boyes and his work in apoptosis, which is important for venetoclax and myeloma. So they had a huge impact on me and my career decisions and my choice to move ahead in this field.
Sounds good. So let's jump right in. So we will discuss a case and then use it as a springboard to discuss the data as we go. So we have a 76-year-old male with newly diagnosed myeloma, revised ISS stage 2 with hyperdiploidy and gain 1Q. And he has multiple comorbidities, including hypertension, hyperlipidemia, both well controlled, has coronary artery disease with PCI almost 10 years ago, and also well controlled diabetes type 2. He's intermediate fit as per the IMWG frailty score, which, as we know, patients can be categorized into fit, intermediate fit, and frail, and he was in the intermediate fit category. He's not very keen on upfront transplant due to the concern for toxicities and quality of life decrement, or I should say not keen on transplant, because at this age, delayed transplant is likely not going to happen. And you're deciding on the frontline induction regimen as to what to give him. First of all, can you give us an overview on how do you approach the distinction between transplant-eligible and transplant-ineligible multiple myeloma in your clinic, especially in patients like this who fall in the gray zone of 70 to 80 years old?
Yeah, thanks. And I think the patient that you've described here sounds like who you would imagine is walking into your clinic with multiple myeloma. You've got a patient who's in their 70s or so, standard kind of American medical comorbidities and fitness that kind of goes along with what you would expect in this age range. And it is often quite challenging to come up with a succinct and easy to define definition of what is transplant eligible versus ineligible. And so we've come up with a variety of different tools to try to do this. I think the IMWG frailty score, as you alluded to, is about as good as we have, but it's difficult. Sometimes we use factors that are hard to put on paper, but you know it when you see it. So what I tend to do is do a pretty in-depth discussion with the patient about what their performance status is, what they're able to do, what are the limitations in terms of what they have in their daily life, and also what their support system is, and try to get a sense of how fit is this person, and then use age as a factor where the older somebody gets, the less kind of room we have to work with some of their medical comorbidities or decrease in their performance status. And I think another thing that makes this really challenging when a patient is walking into clinic is that this is a dynamic thing, that fitness is something that can dramatically change, especially with multiple myeloma, which has such morbidity in terms of pain and its impact on what you're able to do, and that this is modifiable with good therapy as well as physical therapy and trying your best to optimize their performance status. So it's really hard at that first visit to say for sure whether somebody in this frame is going to be fit for transplant or not fit for transplant. And sometimes you just have to start treatment, see how it goes for the first few months, and then make that assessment on an ongoing basis. So yeah, that's how I do it. Sometimes that's something that I have the opportunity to observe. Sometimes patients are referred in for kind of a discussion about transplant and whether or not they're fit for transplant. And if it's not entirely clear at that first visit, you just need to give it a little bit more time. So that's how I make the decision. I do try to implement a couple of geriatric scores like the IMWG Frailty Index, and we are trying to systematically do timed up and go tests, which are also a pretty good validated tool to assess somebody's fitness for transplant. So that's how I try to make that distinction. Now, in terms of how do I approach transplant in this population, it has become a little bit more nuanced, I think, recently with the publication of determination, as well as the fact that therapy is getting better and we're able to successfully manage patients for a long time with non-transplant approaches. That being said, I'm a transplanter, so there is that bias. I tend to believe that if somebody really is fit for transplant, that this is a very, very powerful tool that we have to control myeloma and help to preserve long-term responses, often with less therapy and better quality of life. And this is a one opportunity to do it. I have become less a fan of doing dose-reduced melphalan transplants, or particularly in this kind of borderline patient population, based on the recent kind of long-term data from the French study that showed lack of benefit for melphalan 140. But I will still sometimes offer a dose-reduced transplant for patients with high-risk disease, which again is a broader conversation, but I do still think that's a population that we ought to try to push for more treatment and deeper responses if at all possible.
Yeah, I think that you make a really good point regarding the melphalan dose reduced and the randomized trial that was presented, I think, ASH a couple of years ago, that in this population, if you really have to dose reduce to MEL 140 in a standard risk patient, then you should probably think twice before offering transplant, because MEL 140 was not even able to beat Revlimid Dex. So it comes down to more whether patients are MEL 200 eligible or not.
Exactly. And then we have a higher burden of saying, is this patient actually fit and eligible to get MEL 200? Especially in that over 75 population, I've become less enthusiastic about it.
All right. So, up until now, since, in this podcast episode, we'll focus on the transplant-ineligible treatment. So up until now, there were two main regimens that were the standard of care for transplant-ineligible patients. One was daratumumab Revlimid Dex based on the MAIA trial, and the other one was VRD or VRD Light based on the SWOG SO777 and also the phase 2 study from MGH. So can you give us an overview of the efficacy and toxicity of Dara-Rev-Dex versus VRD in this population? We know that till date, there is no head-to-head data comparing them, but just based on those trials, the top-line efficacy and toxicity results of Dara-Rev-Dex versus VRD in this population.
Absolutely. Happy to do that. And I think this is also really important background for discussion of the trials that I think you're alluding to in a little bit. So the SWOG O777 or S0777 trial was a big phase 3 randomized controlled trial looking at bortezomib, lenalidomide, and dexamethasone for 24 weeks, followed by Len-Dex maintenance versus Len-Dex as a continuous therapy. So essentially just putting in 24 weeks of twice weekly bortezomib compared to Len-Dex alone. Whereas the Maya essentially was the same Len-Dex backbone, but adding daratumumab throughout the duration of treatment. So the efficacy, results from these trials, which is what we're all drawn to initially. So both of these triplet regimens showed improved outcomes compared to the doublet regimens. There was improvement in progression-free survival and overall survival in both of these triplet versus doublet trials. For the VRD, the overall response rate was around 90%. The median progression-free survival was about 41 months. I believe the hazard ratio for that was around 0.7 or so over lenalidomide and dexamethasone. And then long-term, an overall survival benefit was seen. With the Maya trial, the overall response rate for the Dara Len-Dex was about 90% as well, maybe a little bit higher than that. But with ongoing use of 3-drug therapy, that progression-free survival really did take a big jump upwards. And I believe that it was not reached when the trial was reported out, but I think the estimate was that it would be around 65 months. And there was definitely an overall survival benefit seen for Dara Len-Dex over Len-Dex. I will make a caveat here, or a note as well, that they were 2 different patient populations that were enrolled in these trials. So the SWOG trial really was a transplant-ineligible or transplant-deferred patient population. The average age was around 65, and there were a lot of patients in this trial who had stem cells collected. I believe 80% of them had cells collected to use in a deferred basis, whereas Maya really was a transplant-ineligible older population with a median age, I believe, of 74. So those are 2 different populations. The big side effects of the 2 different regimens. So with RVD, you really are looking at bortezomib peripheral neuropathy. And the rates of this were very high in the SWOG 777 study. I think that it was over 50% had meaningful peripheral neuropathy with twice weekly IV bortezomib, which nobody does anymore, but still it's worth noticing. And perhaps that's why when they took a look at subgroups, the older population really didn't have as meaningful of a benefit on a long-term basis with VRD compared to RD. Whereas in the Maya trial, the older patient population, even those who got the triplet did better than those who got a doublet, even if they were a fit and got a doublet. Based on these results, I would say you've got RVD, which is limited duration of triplet followed by Len maintenance versus Dara Len-Dex, which is ongoing use of 3 drugs. But the toxicity profile in an elderly patient population with neuropathy and the risk of falls with bortezomib versus more of an infection risk with Dara, I tend to lean more towards the DRD arm just because this has fewer symptoms. Patients tolerate it really well, and you can often just maintain this for a long period of time.
Yeah, that's, I think, similar to my practice as well. Here also we use mostly Dara-Revdex, Dara continuous. The only thing is, as you said, the infection risk, and as we have seen in the Maya trial, that the infection risk kind of persists, long term. And we have seen in clinical practice, I'm sure you have encountered in clinical practice too, infections, even not only in the initial 6-month period, but even 2 years, 3 years down the line.
Absolutely. There's no question that the infection risk is very real, which I think raises a point of, do you need to use ongoing multiple, therapy, multi-drug therapy? I think we just don't know the answer to that yet. I'm excited for the upcoming SWOG trial that's actually going to take a look at discontinuing daratumumab versus, and actually compare all 3 of these different regimens.
Yeah, that's definitely will be a very useful trial. One follow-up question I had, what is the typical Revlimid dose that you start these patients on in older patients, assuming normal renal function, of course?
Yeah, it's another great question. So in all of these trials, the lenalidomide dose was 25 milligrams, which I think is way too much. in a patient over the age of definitely over 75, but even over 70, often I start with 15 with a normal renal function, just because there's way fewer side effects. You run into fewer problems. Maybe you don't see as fast of a drop in the numbers if you decrease the dose, but it's certainly easier for patients to tolerate. And then you end up with fewer questions about, can we restart this, and fear about the drug. I'm not a big believer that we need to maximize the doses. I think we just need to find a dose that works for that particular patient, that they can stay on and have a good quality of life, especially if we're talking about an older, more frail patient population. In that light, I also decrease the dex. I don't typically do more than 20 milligrams weekly, and I discontinue the dexamethasone entirely, usually after the 9th cycle, if they haven't already discontinued it before then. And I never use twice weekly bortezomib, except if somebody's in the hospital with CAS nephropathy.
Yeah, I think that's some great points. And with Revlimid, same. I can't remember the last patient in my clinic who was able to tolerate 25 milligram. Maybe the very young patients, like 40, 50-year-old, but older patients, definitely 15 milligram.
Yeah, and I get away with 5 milligrams, honestly, for a lot of patients, and they're on it for a really long time. If it's an effective drug, it's probably going to work at lower doses too.
Yeah.
Great. Now that we have a good sense of the standard of care options, let's jump into these 2 recently presented randomized controlled trials from ASCO and EHA, the first being the IMROZ trial. IMROZ was a phase 3 randomized trial of isatuximab plus VRD versus VRD in patients who were assessed to be transplant ineligible due to age or comorbidities, but with an age limit of up to 80 years. Notably, the bortezomib in both arms was administered only during the induction phase, beyond which the experimental arm got isatuximab, lenalidomide, and dexamethasone, and the control arm just got Revdex until progression. Could you give us a sense of the overall and top-line results from the IMROZ trial, Tim?
Absolutely. I think this was really exciting to see the results of this quadruplet therapy in this non-transplant eligible population. We've seen how effective quadruplets can be in a younger transplant eligible population, but now looking at an older, frailer population, this was certainly something of a lot of interest. Top line kind of efficacies here. When you take a look at the overall response rates, they're actually pretty similar. It was, I believe, 91 and 92% of patients responded to each of the regimens. But when you start to look at depth of response, the depth was better for patients who got the isatuximab added. So it was, I believe, VGPR rates were 89% for the ISA VRD arm versus 83% for the VRD arm. And then MRD negativity rates with a depth of 10 to the minus 5 was 55% for the quad versus 41% for the triplet. I will acknowledge those response rates are better in the control arm than what we were seeing with VRD and the SWOG trial and some of the other ones. It's just at least worth pointing that out, that those responses are a little bit better than what we've typically seen. But still, when you take a look at the depth of response, adding in the CD38 antibody certainly seems to help improve response depth. Looking at long-term outcomes, progression-free survival for the ISA VRD arm was not reached, with a median follow-up of around 60 months. And the median was about 54 months for the VRD arm. And I believe that the 60-month PFS mark for the quad was about 65%. Overall survival was not reached in either arm, but it certainly didn't look like it was worse with the quadruplet compared to the triplet, maybe even a little bit of a trend towards better overall survival, although it's immature to really say that for sure. And then in terms of adverse events, I'd say the thing that kind of stood out was neutropenia and infections. So grade 3 neutropenia was higher in the quadruplet arm at 54% compared to 37% for the VRD, and then infections in 45, grade 3 infections in 45 versus 38%. So those were notable increases in terms of the cytopenias and the infection risk. And there were more treatment-related deaths on the ISA VRD arm as well. I think it was 11% for the quad versus 5% with the VRD, but people were also on treatment for much longer in the quadruplet arm. And accounting for differences in exposure, they were fairly similar, still, I think, a little bit higher rate for the quad. But when you take the totality of that into play, you certainly see meaningful improvement in that progression-free survival.
Yeah, a 60-month PFS is a nice time point, although probably picked post-hoc is a nice time point to have some sense of that impact. There also was that the Kaplan-Meier curve in the supplement showing no increase in deaths without disease progression early on. I do think that you highlighted some of the key points in terms of toxicity there as well. Do you think that if you were going to implement this quad in this population in practice, that you would prescribe it as in the trial, or would you make some adaptations and adjustments?
I make adaptations and adjustments to almost everything that is published. I would, as we talked about earlier, I would dose reduce the lenalidomide. I would not do twice weekly bortezomib. I think that they had, I don't know why they designed the trial with 6-week cycles as opposed to 3-week cycles. So that was just a little bit goofy. I usually try to do 4-week cycles, but I think overall, yes, I would make a few adjustments in terms of reducing the dosages or just modifying the schedule a little bit. But I think I would still probably stick to similar time points. I think that 24 weeks, I believe, was the total duration. I think that's an appropriate amount of time to do a quad.
One thing I would like to highlight here is the toxicities leading to death. I must acknowledge that initially when I saw this result, I was very scared. 11% versus 5.5%, almost twice. And it seems like almost 1 in 10 in the quad arm is dying of toxicity. But I'm so glad that in the paper, in the supplement, they actually broke it down by before 6 months and after 6 months, and also the Kaplan-Meier curve for the death with progression and death without progression. And that kind of reassured me a lot, because then it was clear based on those data that I was worried that all of this is coming from higher early mortality with quad, which was not the case. Deaths before 6 months, if you look at the deaths from infection before 6 months, actually similar in both the arms. And it's mainly when you look at after 6 months, which is in the quad arm, patients are on it for a very long time, then that is where there is the imbalance. And that again brings to, Tim, your earlier point, that do we really need to give the isatuximab until progression? Can we stop it earlier and avoid these toxic deaths and also achieve the same efficacy? And I think that's where these trials will be helpful. But, if we had not seen those deaths, maybe the outcome will even be better with quads.
Yeah, absolutely.
So yeah, that was definitely reassuring to see in the supplement. And I'm glad that they did present that data transparently, because just saying that the exposure adjusted toxicity is the same sometimes is not helpful if most of it is in the early mortality, but that was not the case. So with that, we'll go on to the next trial, which is the IFM 2020 BENEFIT trial. This was an academic cooperative group trial. So this, I actually was interested in this trial even more because this is more relevant to our current practice. And it's basically asking the question whether on the backbone of anti-CD38 antibody plus Revlimid and dexamethasone that we are currently using, does a proteasome inhibitor like Velcade add anything, or does it not add anything? So it basically was a randomized trial comparing isatuximab lenalidomide dex versus isatuximab lendex plus Velcade or bortezomib. And it was a phase 2 randomized controlled trial. It enrolled patients who were non-frail, so fit or intermediate fit kind of patients, then 65 to 79 years old, again, an upper age limit of 80 years, and were transplant ineligible based on the clinician's discretion. And in the experimental arm, patients got bortezomib for the first 18 months, and it was once weekly and subcutaneously. So the way that we are currently giving in our practice. So that's also another important piece of data, because it really tells us how much extra neuropathy we have with this kind of regimen of once weekly and subcutaneously. And the primary endpoint of this study is MRD negativity at 10 power minus 5 by NGS at the 18-month time point. Tim, can you tell us the major findings of this study with related to primary endpoint and also the toxicities and limited data that we have on PFS and OS?
Yes, absolutely. Thanks for that good overview. And I would agree that this trial actually, the way that it's designed, may have more of an impact on how we decide whether to do quads, especially for those of us who tend to be using a CD38 IMiD backbone. And then the question more being, should we be adding that fourth drug, not as a CD38, but as a PI. So great study design, I think, that they had, and also with the once weekly bortezomib there. Taking a look at the efficacy, this trial is earlier on. So the median follow-up is much shorter. It's only about 2 years. So we don't have quite the duration of follow-up to look at some of those long-term endpoints that we just saw with IMROZ. But the primary endpoint was MRD negativity. Does adding the bortezomib increase your response rate and then deep depth of response? With the ESA VRD arm, the overall response rate was 85% compared to 78% for the ESA RD arm. Again, these are actually lower numbers than what we are seeing in other randomized trials with some of these backbones, which I think goes to show how difficult it is and why we shouldn't do cross-trial comparisons, especially with single-arm studies. But still a better depth of response, a higher response rate for the quad. If you took a look at VGPR rates, it was 82% versus 70%, and then MRD negativity, which was the primary endpoint at 18 months, 53% of patients who got the quad were MRD negative compared to 26% for those who got ESA Lendex. Progression-free survival and overall survival data was all immature, really, to see that, but a clear, essential doubling of the MRD negativity rates with the use of weekly bortezomib. I believe that they did it for 18 months. And then, as you're alluding to, looking at those neuropathy rates, any grade peripheral neuropathy for ESA RD, so no Velcade, was 28%, 10% of which was actually grade 2 or higher. So it's starting to impact daily living or have pain. Whereas in the bortezomib group, any neuropathy was seen in 52%, 27% of which was grade 2 or higher. So there's still an increase in the neuropathy rates, but still with a year and a half essentially of bortezomib, these are better numbers than what we were seeing with the shorter use of bortezomib twice weekly in some of these other trials.
Yeah, thanks for that eloquent explanation. And one thing I would like to also highlight here, that it's an old cheap drug globally available, bortezomib, and was able to double the rate of MRD negativity at 10 power minus 6. So it was really powerful. I didn't expect that it would increase the 10 power minus 6 MRD negativity also in addition to -5, almost double it. So that was really impressive to see. And also the neuropathy, as even with once weekly, we still see significant increase in neuropathy. So that is another important thing to keep in mind. There was also, no increase in toxic deaths in the first 18 months. That was also very reassuring. It did not really increase the risk of infection-related deaths. So now let's go back to the patient that we had discussed before. So now that we have a sense of the two trials that tested anti-CD38 antibody-based quadruplet, so just to recap for the audience, it was a 76-year-old male with some comorbidities, overall well-controlled, RISS2 with hyperdiploidy and gain 1Q, only gain 1Q as the sole high-risk feature here, and intermediate fit on frailty score. So in this patient, if the decision was not to proceed with transplant, based on these data, would you start off with DARA RD, or would you start off with a quadruplet? I know it's not a black.
I know it's,
but I just wanted to see what you would do in this.
It's a tough call. In myeloma, we have so many randomized trials and so many, big trials with lots of information, and we can take a look at the same data and still not really know what to do with it when we're applying it to that patient. I think a lot of this goes down to shared decision making and what the patient's comorbidities are. And I could make a different decision depending on how that conversation goes with the patient. But I think if I'm trying to something down on paper in terms of what I would do, if this was somebody who we decided transplant is not really what we're going for, I probably would at this point just stick with the CD38 Lendex. I think if you take a look, I think what's most meaningful when we're talking about transplant-ineligible multiple myeloma is maintaining a response. It doesn't need to be MRD negative in order for that to be a durable response. You need a regimen that somebody is going to tolerate. It's not going to, bother their quality of life, and it's going to work for a long time. And I think we've seen long-term what the durability of triplet regimens is. I feel very confident about what I'm seeing with CD38 Lendex. The impact of adding in the proteasome inhibitor, I would say, is less clear on a long-term basis, whether doubling those MRD negativity rates are really going to translate into those more meaningful long-term outcomes. With that, I will also put in a plug here that we're a big ECOG site at the University of Wisconsin, and ECOG right now has a trial specifically answering or trying to answer this question. The EAA 181 or EQUATE trial is giving all patients daralendex for 9 cycles and then randomizing them to either add bortezomib weekly for 9 more cycles or continue daralen to try to see if the addition of bortezomib to drive down or to increase the rates of MRD negativity helps to improve overall survival in these patients who haven't quite gotten there yet. We're really trying to enroll patients on that study. If they really are this borderline kind of transplant ineligible, that's really the answer as to what I would do. But you need to be at an ECOG center in order to go on that trial. And hopefully that'll give us, when we start to pair it with the data coming out from all these other trials, more clarity about the role of a proteasome inhibitor here.
I wanted to build on what I thought was a very thoughtful answer, Tim, and ask you, what sorts of endpoints would you want to see in something like the BENEFIT trial? If you're saying that MRD negativity at 18 months in this population might not be enough to account for the toxicity. So what sort of endpoints would you want to see in a trial like this to actually convince you to change your practice in this population?
I would still be, I think if we saw MRD negativity and PFS and quality of life line up, that would be enough for me. I think that if that really resulted in a better duration of disease control with at similar impact on quality of life and kind of treatment-related deaths, that would probably be enough for me. Overall survival, of course, is an endpoint that I think would be meaningful. But I think that starting to see a difference emerge there, I just think it's too early to say for sure that we need to be doing this up front for everybody, or could we potentially only add in the proteasome inhibitor in the people who most need it?
Yeah, and building on your last point, let's say if this patient was transplant ineligible, but otherwise reasonably fit and was a double hit or triple hit patient. Maybe that is a patient in whom I was willing to do a quadruplet and willing to take on that risk of neuropathy.
Yes, that is somebody. It's a really good point where I think that with unknowns, I'd probably add in the 4th drug, knowing that the MRD negativity rates are higher, because perhaps that will translate into more meaningful long-term outcomes in a population where you need those deep responses in order to achieve it.
Yeah. And based on this data, would you consider quadruplet in patients over the age of 80 who are otherwise fit? Because both of these are the upper age limit of 80. I'm sure we will get some real world data in the future on patients over the age of 80, but at this time, would you consider quads on a case-by-case basis over the age of 80?
On a case-by-case basis, I think I would. I think age is just a part of that fitness calculator that we have in our minds. I think a very fit patient in their 80s, I would do it, but I'd be very aggressive about dose reductions or discontinuation of drugs for toxicity. But yeah, especially in those higher risk patients who are older, if they're fit, I would consider it on a case-by-case basis.
I was going to ask a sort of the flip side to that question, which is, why do you think, as someone who does a lot of clinical trials, why do you think these trials that were designed to assess transplant ineligible patients still had upper age limits?
Boy, that's a good question. I don't know. I think perhaps the concern when we're opening up quadruplets to that much older population is that it's going to be too toxic. And so trying to control those variables a little bit better, I think that's one potential explanation. But for instance, the ECOG trial that I referenced doesn't have an upper age limit. I enrolled a patient who was 86 years old onto that trial. He got the quadruplet arm. He did great. You have to take fitness into account. But yeah, I do hope that as we move forward, age, you can't ignore it, but I don't think that we should be setting strict age limits, especially with transplant ineligible studies.
Yeah, I was
There
also
was-
I was saying I was also surprised to see the upper age limit because we have not seen that many transplant ineligible trials with upper age limit in the past, like Maya trial up to 90s. But I think you are right. I feel like maybe the companies were a little bit worried about early mortality signal with quads in those older patients, and they wanted to control the variables as much as possible, given IMROZ was a registrational trial. So that could be a reason.
Yeah, no, I think it's a vexed question though. If you're going to see an early mortality signal, would you not rather see it in a than when people have to make it up as they go along? But no, I thought that was a very good explanation.
Those of us who treat patients, of course, want to know that. But yeah, it's hard to say. I think that, to your point, if it is much more toxic and we start to extrapolate this and we see a lot of early deaths, that is going to scare people away. And no matter what the trial results are, if it's not applicable to the patient population who you're applying it to, then it's not going to be meaningful results.
Totally. So there was another trial we wanted to also add into the mix that was presented at ASH 2023, the GEM 2017 FIT trial, which enrolled patients 80 years or under who were transplant ineligible but had to be fit overall based on their geriatric assessment. And there were 3 arms to this trial. There was a VMP RD arm, a KRD arm, and a DARA KRD arm. They presented the data from the 18-month time point, and there'll be MRD guided treatment modification at that point. And so could you tell us a little bit about the comparison between KRD and DARA KRD in this transplant ineligible population?
Sure. Yeah, this was another, I think, very insightful clinical trial, and we've gathered a lot of, I think, useful information from it. And as you alluded to, there were 3 arms to the trial, one of which was VMP followed by Len-Dex, which isn't really what we would use in the United States typically, but KRD, DARA KRD certainly is. And high level response and what are the top line results here? What they showed in this trial was that DARA KRD had significantly improved depth of response. MRD negativity rates at that 10 to the -5 time point was 79% for the DARA KRD group versus 66% for KRD. And I believe it was worse than that for the DARA VMP arm, although I don't really remember the number for that. Progression-free survival, though, at the point in time when they were taking a look at this was very similar. It was 83% at the 30-month mark for KRD versus 79% for the DARA KRD arm. So despite that increase in MRD negativity, similar PFS and then toxicity-related deaths were actually substantially higher with the quad arm at 8.5% compared to 3.2%. And so I think that what many of us have taken away from this trial is that quads can be tough on particularly older patients. And I think maybe that's because carfilzomib was used in this trial rather than bortezomib. I think those of us who have used enough carfilzomib, it certainly has a reputation of having quite a bit of cardiovascular toxicity with hypertension and heart failure and things like that. But it is a drug that carries a lot of toxicity in older patients. And so we have to be very mindful of that, especially when we start to combine it with more and more drugs. And so I think that the caution from this study, which was a very good study, I think there was absolutely good rationale to study this regimen in this population. As you start to increase the efficacy, a more elderly, frail, unfit population is really has the potential to be harmed by going for deeper and deeper responses, which is why those kind of goals that I tend to have is what I shoot for in this population, is finding an effective treatment that people can tolerate and has good quality of life. I think that there is a balance to be struck there. And right now, I think all of these trials are helping to figure out what the right balance is.
Yeah, I think that's a great point, Tim. And also, these are mortality within the first 18 months. So these are like the early mortality, higher in DARA KRD versus KRD. And just also for the record, for the GMG Concept Trial, which was isatuximab plus KRD, they also had 2 cohorts. One was transplant eligible and one was transplant ineligible. And they also found that it was not randomized, of course, but they also found a similar signal of really high grade 3 or higher cardiac toxicities in the transplant-ineligible cohort, but not really in the transplant-eligible cohort. I think it was like almost 9 or 10-fold higher. Since I've seen these data, I've been very careful with carfilzomib-based regimens in older patients, and given that we have this signal of toxicity and as well as toxicity-related deaths.
And carfilzomib is a good drug, clearly a very potent, effective medicine. But I think that we just have to be mindful of what its toxicity profile is as we combine it, and to be cautious, especially in a newly diagnosed patient who has comorbidities.
Yeah, for example, in ISKIA trial, we barely saw any cardiac toxicity, right? So I know Eddie was surprised at why there was so less cardiac toxicity in ISKIA. It's because population was much younger and fitter in that. But when you're talking about older patients, it can become a little bit nuanced. Eddie, did you have any follow-up from this?
Oh, I think the main takeaway is clear, which is be a little bit more cautious with carfilzomib in older patients and much older patients, and that its toxicity profile is age dependent or fitness dependent. And I think that's a key takeaway there. But I think if you put the three trials we've discussed together, other than the high risk patients, are there any sort of clinical takeaways that you think you'll take back to your practice when you're looking at transplant-ineligible patients?
I think that what I would take away from this is that a CD38 antibody still adds to the durability of response, even in patients who got a proteasome inhibitor triplet. I think that is the clearest. We know that proteasome inhibitors will help to deepen response. That's what we saw from BENEFIT. What we saw from IMROZ is that isatuximab helps to prolong the duration of benefit, even when added to VRD. But to be mindful that adding more drugs does have toxicity, and that we have to tailor this for individual patients. And I think that what we're all going to take back from this is somewhat of reassurance that probably by adding more either isatuximab or bortezomib here and there in selected circumstances, that is appropriate. That more often than not, patients are going to be able to tolerate that, but that maybe we can tailor this to reduce toxicity over time.
All right, I think it was a great discussion and summary of the two trials. It was very timely. Thank you, Tim, for making the time to come on the show. And we hope to bring you back again for other episodes on myeloma. Thank you very much.
Sounds good. Thanks for having me. It was a great discussion.
Thanks so much for joining us, Tim.